So it is such an honor here to have Nila here. I've known Nila from Harvard. At the time that I met Nila, I was at Harvard School of Dental Medicine, mainly lecturing and medical school. And Nila was the president of the professional student government. Everybody at Harvard knew Nila. She was brilliant, and she was one of the brightest, if I cannot say the very, very brightest person at Harvard. She has got 2 degrees. She's a doctor and she's a lawyer. She's very young. And one day she will be maybe the next president of the United States.
Oh my goodness. that is quite an introduction. I can't say, I deserve all that, but that is very, very kind.
So just a little bit about Nila's journey. She earned her Bachelor of Philosophy in Neuroscience and Psychology. And she also has a Bachelor's of Art in Sociology from the University of Petersburg. She started her MD at the University of Petersburg School of Medicine, but then she realized the interplay between medicine and law in the current policy landscape and wanted to combine these 2 passions, law and medicine. In the middle of medical school, she took a leave of absence to earn her JD from Harvard Law School, where she also played a role in several leadership positions throughout the university, including president of the graduate and professional student government, like I just mentioned. And then from there, she returned to Petersburg to complete her MD, her medical degree. And after receiving her doctorate, she completed her medical training at Yale University in internal medicine, where she also had several leadership positions, including co-president of all resident and fellow trainee employees at Yale. At the moment, she serves as Associate Medical Director for Transitions of Care at Centara Healthcare, a health system which includes 12 hospitals throughout the states of Virginia and North Carolina in the US. And before the COVID-19 pandemic, acute care telemedicine was close to science fiction, but the hospitals overburdened, as you can imagine. New solutions to care for the sickest patients from the home needed to become a reality and fast. And Nila was able to expand these programs throughout several hospitals, helping many, many, many different people. So this is just a small introduction about Nila. She's going to tell you a little bit more about herself, her journey today. And I'm going to leave it up to you, Nila. I'm going to share my slide.
Yeah, sure. And I'll let you know when to go to the next slide.
Yes, you let me know. Okay.
Well, first of all, I just want to say thank you so much for this opportunity at We Speak Science. I'm really honored to be a featured lecturer, even though my lecture will probably be shorter than some of your other ones in the past, but I really appreciate the opportunity. I'll be speaking today on heart disease and prevention in communities of color, which is something I focus on in the hospital and in my position. And before that, I'll give you a little bit of my journey. Next slide. All right. So in terms of my journey throughout STEM education, I guess it all really began with my parents. So, I really appreciated Dr. Zali's story, your strength and your efforts throughout all of your whole life, especially as a refugee. I related to that in a different way, not myself, but my parents also came from Bangladesh. They were refugees during a very violent and genocidal civil war in 1971. And they escaped and they were able to come to America and finish up their medical degrees here and training here and become doctors. And because of that, they really instilled a very strong work ethic in me. And also that love of medicine and love of caring for other people using all of this science and technology education that we have. So when I was in high school, I decided to apply to college. And in the process, what I found is a very specific type of program called a guaranteed admission program. They were not as common 20 years ago. However, they're actually pretty, common today. So I encourage all of, the students listening today, if you're interested in medical school and you happen to be in a program that is not British based, where you go from high school directly into medical school, or if you're something more in the US where you have to go to college, still try to pursue these guaranteed admission programs, because one of the advantages of them is that you do not have to take the MCAT or medical entrance test. That is a huge, huge thing, because as you are probably aware, you have to study for months, sometimes even up to a year for the MCAT in order to get a really great grade and to get into medical school. So luckily, I had found one of these programs. I applied to it from high school, and they really liked me, so they took me. And I was very honored to be one of their students in their program. Because of that, I did have a lot of extra time when I was in my undergraduate career. So I decided to triple major in neuroscience, psychology, and sociology, because I was really intrigued by the brain behavior connection. And because I didn't have to study for the MCAT, I also discovered a passion for law and government. Now, you can imagine, here I am, I have guaranteed admission into the medical school. Now I've discovered this passion for law and government. What do? I talked to my mentors, I talked to my family, and they said, well, you can apply to law school. You have medical school sitting right there. But if you really, really, truly want to, go ahead and do that too. And I did. And what I decided to do was talk to my medical school and say, hey, I know this sounds crazy, but I really want to go to law school. Is it possible for me to do that while I'm in medical school? They said, well, it's not exactly possible in medical school, but maybe you can take a leave of absence. And, it took a long time to negotiate with them, but eventually they did allow me to. And I chose to do law school in the middle of medical school for a couple of reasons. One was because I think that combining all of that together really helped understand how law and medicine works, hand in hand, but also because the first 2 years of medical school, which many of you may or may not know, is called the didactic portion. And what that means is it's lectures, it's a lot of book reading, but it's not really a lot of hands-on medicine. So you get to learn the biochemistry, you get to learn pharmacology, all of those different things, anatomy, but you're not really applying it just yet. Then the next 2 years of medical school is really where you get to take care of patients. So I decided that's a pretty good break. I'm going to try to go to law school in the middle. And my medical school teacher said, well, good luck, because even though you didn't have to take the MCAT, guess what? You will have to take the LSAT, which is the law school admissions test. And I was like, oh boy, okay. And I had to learn how to study for medical school with anatomy and pharmacology and biochemistry, all those tests back to back to back, while also studying for the LSAT. And to be honest, that was a tough time, but I survived and I did well enough on the LSAT that eventually I got into many different law schools. And very, very luckily, Harvard Law came calling one day and they said, hey, we have a spot for you. Are you ready to go? And I said, absolutely, 100%. Harvard Law, what an amazing place, one of the top law schools in the country. Harvard University, so prestigious, so many brilliant minds. That is where I met Datina during that time. And, the stuff that we did there, the lectures, the events, the organization, the leadership, it's a once in a lifetime opportunity. And so I encourage all of you are watching this lecture, if you, even when you think you can't, just keep going and shoot for the stars, because maybe you think, oh, maybe I don't have the grades, or I don't have this, or I don't have that. Just put yourself out there, because you really never know where it's going to end you up. So after law school, I concentrated in healthcare law there, also did a lot of leadership that I think Datina already mentioned. I decided I was at a crossroads, and I could work in Congress, I could do this and that, after a Harvard Law degree. But to me, something told me that what was more important was actually going back to medical school and learning how to take care of these patients. Because without that, all of that STEM education that I had, I wanted to make sure that I put to use and actually knew what I was doing, what I was talking about, if I was going to make any policy changes in the coming years. So after law school, I decided to go back to medical school to the University of Pittsburgh and finish up those clinical years. So I've completed those clinical years. I learned a lot about how to be a doctor during that time. And then I had to, sorry about that. That was my security system going off. I had to go basically to medical training. So for those of you who are unfamiliar with the US system of medical school and how to get in and how to become a doctor, after you go to medical school, you have to do anywhere from 3 to 7 years of very intensive residency training. So what does that mean? That means you have to put in about 100 hours a week for 50 weeks a year for 3 to 7 years of seeing patients basically on a constant basis. And it is a very, very tough time, but that is where you really learn how to take risk, what it means to be a doctor and make life or death decisions, and what it means to think on your feet with all of these things that you have learned, starting with anatomy, biochemistry, and pharmacology, right? It's actually putting it into practice. So I applied, and I was luckily offered an opportunity to complete my training at Yale. And in their internal medicine program, one of the things that they also do, besides teaching you the medicine and how to take care of patients, is they also concentrated on leadership and policymaking and social determinants of health and how that affects patients and communities. That training was very vital, because when I eventually graduated and applied for a job, back in my hometown in Southern Virginia, that was vital because they looked for people who had extra experiences, STEM definitely, but also leadership. And I think that Tina will, vouch for that, in that leadership and that type of training is so vital in a different way, but it's so important because it gives you that confidence to proceed, and it also gives you that confidence to lead teams. That's how I ended up where I am today. I'm now the Associate Medical Director for Transitions of Care, as Tina mentioned, at Centera Healthcare, which covers 12 hospitals in the state of Virginia, North Carolina, in the US. And in that position, my main role was to figure out, how do we expand healthcare to people who are sick enough that they need to be in the hospital, but the hospital does not have any beds. And over the last 2 years, that's what I've done, is expanded those types of programs and figured out, how do we get medical supplies? What kind of medicines will work in the home setting, that we can actually provide? How are we going to get these teams functioning, and how are we going to make sure the patient's vitals are okay? So that's what I did for the last couple of years. And all of this education really came into play. And like I said, I encourage anybody to, no matter what, just keep going. And, there's a lot of other lessons that I learned from that as well. But can you go to the next slide? Oh, yes. So basically what I was saying, from this experience and from my career journey, what I learned was, keep going. If somebody tells you no, find a different way. When I was an undergraduate and they said to me, when I decided to triple major, right, with all that extra time. I actually had an advisor tell me to my face, she said, there's no way that you can accomplish this. I don't think you should even try. You should just stop here. And luckily, I know, right? Luckily, I did not take that. I said, you know what, that might be her perspective, but I'm going to plan it out. I'm going to try my best and we're going to do this. And because I didn't take that wall and I didn't let that wall deter me, I was able to accomplish that. And same thing with going to law school in the middle of med school. My medical school, they're great medical school, but sometimes they can be pretty tough. And they also were in a position where they said, you know what, we do not want you to go to law school in the middle of medical school. It's going to interrupt you becoming a doctor. It's going to make you not as good of a doctor. Law doesn't relate to medicine at all. And I told them, that's a really interesting perspective. Law absolutely relates to medicine. It relates to how we practice medicine. It relates to the healthcare that you get, depending on the country you're in, insurance, right? Regulations. When we talk about the pandemic, who is coming out with regulations about how far apart we need to be, what schools are shut down, right? All of this is related together. So I had to negotiate with them and they eventually allowed me to. But again, it was not taking no, making sure you negotiate and making sure that you have a plan and putting in that time and focus. And whatever your purpose is, whatever your passion is, basically don't let anybody tell you no, pursue it relentlessly. Okay, relentlessly. Okay, so transitioning over into the bulk of the lecture, focusing on heart disease today. The biggest question we have is, why does heart disease matter? So it's not just a trend in Western countries, although maybe over the last 50 years or so, it had been mostly a trend in Western countries where the number one killer was cardiovascular disease. But now it's a leading cause of deaths globally. Why is that? We can attribute it to many different factors, but one of them is the fact that sort of a westernized diet with a lot of salt and a lot of fat has kind of made its way across the world as a common diet. This unfortunately kills millions of people every year. 17.9 million people died from cardiovascular diseases in 2019, and that was 32% of all global deaths. Which is huge. And specifically in the US, that's about the same proportion. About 1/3 of deaths are due to cardiovascular disease. This creates a huge burden on the healthcare system in the US and around the world. But in the US, about 216 billion per year, and about $147 billion in lost productivity, which means people who are caring for families, people who are working. Now, if they have a heart attack, obviously, a lot of that stops. And so the economy stops in a way. But it's not just the economy, right? When we have to look at it from a human perspective, this is a human toll. If 1/3 of the world dies every year from cardiovascular disease, then we have to do something about it. And we have to know why and where it begins. Next slide. So how does heart disease start? Let's go back down to the molecular level, which I think is one of my favorite parts. We know that heart disease starts with a buildup of cholesterol plaques in the blood vessels. And what that does is it eventually closes off the blood vessels due to a plaque rupture. And that clots off the blood vessels and stops oxygen from getting to whichever organ that blood vessel supplies. Cholesterol forms many different types of particles in the body. One of the main culprits of heart disease is what we call LDL, which is a low density lipoprotein. So what is the structure of this LDL particle? You can see it here on your screen. I like to call it a bubble. You can kind of think about it that in a more simple way. but the membrane is composed of phospholipids, which are the main component of most cell membranes as well, but also different particles that are not cells, including this LDL bubble, let's say. There's also a larger protein called apolipoprotein B. This creates a structure for that membrane and kind of holds everything together. And then in the center, which is kind of the biggest culprit of all, are cholesterol esters. So you can see the chemical formula for cholesterol there on the side. An ester is when that fatty acid is added to the cholesterol, but either way, it's still a derivation of cholesterol and it's full of that inside that bubble. Okay, so, okay, there's these LDL bubbles. So what? How do they cause heart disease? Let's go to the next slide. So the way that LDL causes heart disease is that it penetrates through the endothelium into the walls of the artery. So an endothelium is basically that first layer of cells in the artery wall. And if there's any gaps, you could even think about it like a cut on the skin, right? If there's any gaps, these large LDL molecules will get into those gaps and start to infiltrate the cell wall. Now, who cares? Okay, so the bubbles are now in the wall. Why does that matter? Well, it matters because once they get into the wall, they become, that lipid outer layer becomes oxidized, and it causes a reaction with that big protein, that structure protein called apolipoprotein B. When that is modified, it starts sending out signals in a way that it's an intruder, it's an invader. And when it sends out those signals, you can see in this bottom portion of the picture here, the monocytes, which are a type of white blood cell. And as we know, white blood cells are kind of they're the immune system of the body. They protect us from invaders, and that's exactly what they're doing. So the monocytes detect these signals and they start to invade the cell wall looking for the intruder. As they are doing that, they receive chemical signals to turn into what is called a macrophage. Now, a macrophage is kind of the successor of a monocyte. It is a cell, a white blood cell, that its primary function is to engulf invaders, right? So what it does is it sees an invader, it's gonna eat it, basically. It's going to consume it. And as it does consume all of these LDL particles, slowly the macrophages get so filled up, they look like they are a bubble full of bubbles and become what's called a foam cell. Why do foam cells matter? Okay, so now they've trapped the LDL particles. Great. Well, not really, because when a macrophage becomes a foam cell, it's basically a dysfunctional macrophage. So it starts to put out signals itself saying, hey, I'm an intruder. I am creating a bunch of inflammation. And the body's response to inflammation is to wall it off or destroy it or calm it. But mostly it's to wall it off. And so with the foam cell, what it does is it secretes cytokines. Cytokines are chemical signals to the body saying to start this inflammatory reaction, to wall it off. This signal goes to the smooth muscle cells, which you can see kind of at the bottom there. They're hanging out on the other side of this wall, this endothelium. And they say, okay, well, here's an intruder. Oh.
Baby,
Please.
Oh, sorry. I think we got an accidental call in there. But so basically what the smooth muscle cells do is they say, okay, we need to wall off all of these foam cells. They start to create a protein called collagen. Collagen is a very fibrous protein. It's basically scar tissue, if you think about it in one way. So they try to wall off these foam cells in this big scar, and they're like, we're doing a great job. Well, they are doing a great job at, walling these off. Unfortunately, this wall, if you can kind of look at this picture, basically become small little hills that start to protrude into the blood vessel. Now, you can see why that could be a problem, because if the blood vessel is only so big, now there's a hill in it, it's going to reduce the area that the, I think somebody might be.
Can I just 1 second? Nila,
Yeah,
I just want to
yeah,
make
sure, no
sure
problem. Yeah, for sure.
Just want to mute everyone, just making sure. Oh, he's muted. Okay. Please, everyone, if you can keep your microphone muted, we would greatly appreciate. Thanks.
Okay, I think we're back, right?
Yeah, we are.
Okay, perfect. So as you can imagine, this hill is protruding into the blood vessel and creating a smaller and smaller space for the red blood cells to get by. Now, maybe that's a problem. It is a problem, but it's not too much of a problem because it doesn't usually, these plaques, these little hills now called plaques, don't take up too much of the space. But as they get bigger and bigger, one thing is basically certain to happen at some point is that they will rupture because they're an unstable group of proteins. When the plaque ruptures, this little hill starts to split apart at some point. The body says, oh, wow, there's a rupture in the endothelium. It might be like a cut. Something is happening. I need to stop this. And what does the body do? With a rupture, it starts to create a clot. That is the death-defining piece of this, is that once these plaques rupture, as you can see sort of in this last picture of the blood vessel on the right, a clot starts to form. Once the clot starts to form, it's very difficult to stop, and the clot gets bigger, and whatever's remaining, whatever is left of that small area that the blood vessel still has is completely covered and occluded by the clot. That stops blood flow, that stops oxygen, and eventually leads to a heart attack or whichever organ unfortunately dying. So, how do we prevent heart disease in the first place? Well, the key is actually LDL. There are many other issues as well. There is high blood pressure, diabetes, all of those things. But the main marker that we try to focus on is reducing LDL. So you can see here from the 2020 International Society, these are their guidelines for what level of LDL in the body doctors should target. Now, it depends on your risk factors. What are risk factors? Is there anything that makes you more likely to have heart disease, heart attacks, and stroke? So if you are you have a lot of these issues, you have chronic kidney disease, diabetes, high blood pressure, which is hypertension, you should probably go for a level of less than 70. And maybe if you don't have as many of those, but you might have a family history, you should go for a level that's less than 100. And maybe you don't have any family history, but you still consume a mostly Western diet, you should probably go for less than 115. Now, I put number 4 here at the bottom because although it's not in the International Society guidelines, they are in some European guidelines where if you're in a very, very high risk group where you have all of these conditions, plus you have a genetic, ethnicity, or race related likelihood of getting heart disease, you should probably go for less than 55. Now, you might ask, how do they come up with most of these markers? And the truth of the matter is, for lack of better terms, is that most of these studies that found these levels of LDL were done in the 1950s, 60s, and 70s in mostly European populations. Now, that is great, but at the same time, it really doesn't cover the diversity of populations that we have in a lot of countries today, and also doesn't cover the diversity of the entire world. So we're sometimes using these levels when maybe in a different population, there might be a different risk of heart disease, and actually we should be targeting something less. How do we find this out? And how do we even know that this might be true? We can go to the next slide. So we know that this is probably likely true because we can see the disease burden in communities of color that vary so much from disease burden in European or white populations. And it's very interesting as to understand, why is that happening? You know, what is going on here? So for instance, in non-Hispanic Black populations, they're twice as likely to die of heart disease. 47% of Black adults have been diagnosed with some type of cardiovascular disease compared to 36% of white adults. And I will have to say, most of these statistics are based off of US populations. 4 out of 5 Asian adults still have uncontrolled high blood pressure, which is a huge risk factor for heart disease. And also Hispanic adults and Black adults, 3 out of 4 still have high blood pressure, and that's compared to white populations. And then if we look at even Native populations within the US, 1 in 4 adults have diabetes compared to about 1 in 12 in the white population. So there is something going on with these risk factors. And then even in South Asian populations, so those are people from India, Bangladesh, Pakistan, etc., they have about 25% of heart attacks that occur under the age of 40, which is pretty unusual, 50% under the age of 50, and there's a 40% chance of mortality compared to other populations in the average population. So we can see that somehow there could be genetic, ethnicity, and race-based differences in how likely we are to have heart disease. And if that's the case, what do we need to find out about these genetic differences, and how can we treat them more effectively? So along those lines, I will say the research is very ongoing. I would say it's fairly new in the last 30 years or so. There's a lot of different research opportunities involving different genetic populations and how heart disease happens in those populations, and what are the molecular markers we really need to focus in those different populations. There's actually a really great study called MASALA, MASALA, at Stanford that kind of looks at these different genetic populations as well. But again, this research really isn't here yet. We are still using these markers from the 1950s in mostly European populations on everybody. And as we can see, it's not exactly working. So what we're trying to do, and this is kind of where I advocate for the interplay of law and medicine, is we have to give more research funding into figuring out why these genetic differences happen. I think there was somebody there.
Yeah, I think it's the same person. Sorry about that, Nila. I don't know.
No problem. That's okay.
We'll edit it afterwards. Don't worry.
Yeah, no problem. But long story short, what I'm trying to say is that there are a lot of research opportunities. There's plenty of places to grow and figure out what the genetic differences are, and what levels of cholesterol, BMI, A1C, which is a marker of diabetes, blood pressure, and other preventative markers we need to target for each different individual from a different background. I actually had a really great opportunity to speak on a law that in the US passed the House of Representatives this summer, which was actually dedicated to looking at why there's different rates of heart attacks in these different populations and what we can do about that. So I was really, proud and excited for the fact that there is going to be more research funding dedicated to figuring out what are these genetic differences. So that's it for today. I've just wanted to leave some time for some questions, either about the molecular process or law and medicine and research and funding or disease burden in communities. So just let me know what questions you have.
Anyone has any questions? I think they might be a little bit shy.
Oh, I'm sure.
Well,
Well,
I have a question for you, Nila. According to you, what do you think in terms of the heart disease, cardiovascular diseases would be, and focusing also in precision medicine, which is pretty much the future of medicine, and a lot of research is going on. How do you relate precision medicine in cardiovascular diseases? Is that something that has started in the US yet? Do they still look at the markers or any other specific things to see the patients before?
That's a really great question. And I would say this, currently the answer is no. So there is a lot of research into sort of genetic causes of heart disease, but unless you have a very rare disease, there's a condition where you create almost 10 times as much cholesterol as the next person. That's a very rare genetic disease. But in terms of on the average, to look at how genetics is affecting your risk of heart disease, it's not really being done. I think it should be done, and that's kind of what I'm advocating for with this. Even if it's not done on a genetic level, sometimes what doctors do is we use other clinical markers, so estimates. So we can say, okay, we don't have the gene profile of this person. Maybe that's not cost effective, or we don't have the technology yet on a large scale. But we can use other substitutes. Like, for instance, if I went to the doctor, they would ask me, what is your family history of heart disease? That can be a marker. For me, unfortunately, my mother had a heart attack. She's still alive today. But that is a big marker of, okay, your mother had a heart attack. That might mean you could have that similar likelihood because you are a genetic individual of that individual, right? There's other things we can use like ethnicity and race. Because if we see, okay, in South Asians, they have, 40% more mortality from heart disease, that could be an influence on me as well. So, for instance, my primary care doctor might say, okay, for most people, I might say we should target this LDL level of 115. But because of your history and ethnicity and everything, maybe we should go to that under 70 or under 55 even, and then they might either prescribe me medicine, talk about diet, talk about exercise to try to get me to a healthier level. So unfortunately, it's not being done. I wish it was.
And in terms of precision medicine, just generally speaking, I know the topic today was cardiovascular disease. I'm just interested myself because part of my job now is to train medical doctors on genomic medicine, and NHS, which is the National Health here in the UK, is pretty much obliging all the doctors to learn genetics because they are very much focused on genomic medicine. So all the doctors in the UK now are taking, well, most of them, not all, are taking are doing masters in genomic medicine or precision oncology. How is this in America? Has it started yet?
So there are courses. So I would say, when I was in medical school was back in 2010 was when I started. So it's been a while now. Even then, in medical school, we had at least one course completely focused on genetics. But one course is not enough. These days, at least from what I know about current curriculums, they're increasing that focus on genetics. There are masters on genomics that you can do, but they're more ancillary, so it's not really mandatory for doctors. But that's a great point that you bring up. I think they absolutely should be in some ways, because I think that is the future of medicine, is to really get down to what do you specifically need so that we're not blanket treating people all the same.
Yes, absolutely. So Jasmine has a question. Jasmine?
Sure.
I had a question regarding what you would say is your philosophy when studying medicine and why you decide to become the doctor that you are today.
That's a great question. Well, I would say that my philosophy in studying medicine is mostly targeted at helping people. And I know that sounds kind of generic, but honestly, with my parents' influence being physicians, especially in their village back in Bangladesh, they were the only doctors sometimes for hundreds of miles. And it really came from more of a community service philosophy for me. I could have stopped at being a lawyer and not gone back to medical school, but in those times I thought about, we can help so many people with both practices, but with medicine, I mean, you're really there for life or death decisions, right? And those are the times I think when people sometimes need the most help and they're the most vulnerable. And I wanted to be there for them in those times, as well as other times and policymaking on a higher level. But that's the reason that I went back to medicine, was to help people in their darkest times.
That is so inspiring, Nila. That was a very inspiring answer. And Paolo?
Thank you, Miss Sally, and just want to say thank you so much for your presentation today. I had a question around spotting genetic mutations in babies when they're born, or even when they're being formed in the womb, and even if they're developing some sort of diseases before birth. Is there any way to spot that?
Yes. So, I'm not a pediatrician, but, we in medical school, we do kind of cover a lot of different care for different populations, including obstetrics and gynecology, where they do a lot of genetic testing nowadays at different stages of pregnancy for the mother and for the baby to see if anything's going on. So the way they do most of that is they actually will do what's called amniocentesis, which means they take a little bit of the amniotic fluid, which is the fluid-filled sac around the fetus, and they will actually send it for genetic analysis to see that. That being said, that's more of an older version. There are newer methods where they actually take a little bit of some placental tissue, in a even less invasive procedure, and are able to genetically analyze that as well. So it's actually becoming earlier and earlier. Before, I would say, think about sex chromosomes and telling if, is your baby a boy or a girl? We used to only be able to do that around 20 weeks. Now we can do it even closer to, I think it's 16 weeks at earliest. And that's because basically genetic technology is improving all the time, and we're getting to do this with less and less amounts of body fluid and tissue, which is better for the mom, better for the baby.
Thank you.
Thank you so much. I don't think there are any more questions. We don't want to keep you longer, Nila. We know you're
Okay.
So really appreciate it. Thank you so much again, and best of luck with everything you're doing. I'm sure you don't need luck.
Well, thank you so much. I really appreciate it. And honestly, if any of your students have any questions or mentoring questions, I'm here and I'm open. So feel free to share my email as well.
Thank you so much again. And yeah, we hope to have you in the future as well.
Okay. Thanks so much, Tatina. Thank you, everyone.
Bye, everyone.
Bye-bye.
Bye. Thank you for attending. Bye-bye.
Bye.
Thank you.